In this video, I'm going to be explaining and demonstrating the prone thoracic extension or prone thoracic closing manipulation. And this is typically done when a person has thoracic hypomobility at a particular segment or segments, or mechanical neck pain. And so again, you're doing this not only to decrease pain, but to increase thoracic motion, particularly into extension. Now, of course, I'm going to have to find the specific hypomobile segment to be manipulated, but before I do that, I really just like to find, in general, the patient's spinous processes, because that tells me where the patient's midline is, and then I just go relative to that. So hand positioning in this manipulation is what we call east-west positioning. So cranial up here would be north, caudal down here would be south, and we could say up here by the left hand is east, down here by the right hand is west. So left hand pointed east, right hand pointed west. Okay? And notice that the hypothenar eminence, which is where the pisiform contact occurs, is over the facet joint on either side of the segment that we're going to be manipulating. Now, as with any manipulation, we need to make sure to take up the soft tissue slack in that area. So the way that we do that is from this east-west positioning of the hands, we're going to apply a firm vertical force or pressure downward. And while maintaining that pressure, we're going to rotate our hands into the north-south position, where one hand is now pointed north or cranially, and the other hand is pointed south or caudally. Okay? And note that the rotational axis is right on the hypothenar eminence, or more specifically the pisiform bone of your hand. Okay? So that means that that contact point throughout this rotation does not change. So my right hypothenar eminence is on this facet joint at that level, and my left hypothenar eminence is on the contralateral facet joint at that level. Because that is the rotational axis, the contact point does not and should not change. All right, now back to the patient demonstration. Once I locate the hypomobile segment, I'm going to place my hands with hypothenar contact over the facet joints of that segment, and I'm going to use that east-west positioning that we talked about. Okay? Again, this hand placement can be kind of awkward the first couple of times you do it, but look at what we have here. So here's my left hand. So my left hypothenar eminence, my left pisiform, is really over the patient's right facet joint at that level. And this is my right arm over here. So my right hypothenar eminence, right pisiform, which is covered up, is over the patient's left facet joint at that level. So this is my east-west positioning. One hand's pointed this way, the other hand is pointed out the opposite direction. And I'm going to push down firmly, give some firm pressure in the downward direction toward the table. Now from that east-west positioning, I'm going to remove soft tissue slack around this segment by maintaining that firm downward pressure and rotating my hands into the north-south position as you see right there. So because you're rotating about the hypothenar eminence, your hypothenar contact point should not change. You should still be over those facet joints. The only thing you're doing is removing soft tissue slack. Okay? So now in the north-south position, one hand is going to be pointed caudally, the other hand is going to be pointed cranially. And we're going to hold this position from here. Here's what that looks like all together. So get that hypothenar contact, east-west positioning, downward pressure, take up the soft tissue slack into the north-south position. Here's a view from the side. Hypothenar contact, east-west positioning, downward pressure, take up the soft tissue slack into the north-south positioning as you see right there. Now, from this position, I'm going to have the patient inhale maximally, okay, while maintaining that pressure downward. So they're going to inhale. There's the inhale. You can see the back of the patient rise up. And then I'm going to have them exhale. And as the patient exhales, I'm going to maintain that downward pressure with my hands and essentially follow them down as their back starts to descend with the exhalation. Okay? And then near end range exhalation, I'm going to apply a high velocity, low amplitude thrust vertically downward. Okay? There's the exhale, follow down, and thrust. Now the general rule for dosing manipulations at a particular level of the spine is you'll start with one manipulation, and if you have an audible or palpable cavitation, you're done. You don't need to manipulate again at that level. But if you perform that manipulation and there's no audible or palpable cavitation, then the rule is you're going to do one more identical manipulation at that level, but no more. So bottom line, you manipulate once. If there's a cavitation, you stop. If there's no cavitation, you do one more manipulation. So 2 maximum. And always use the test, treat, retest model. Thank you for all your support. Be sure to check out my Instagram for cool science and not science stuff.